in my experience of last 8 years, we found that it is useful in selected cases, and the number of cases what we have done and what are the results I am going to present to you now. Now we have 2 centers in Hyderabad. Both places we do shockwave therapy, and 2018 we got the first machine, in 2020 we got the second machine. And this is a machine what we have taken in 2018. So we all know this machine is portable, easily learnable. It has got a soft probe which has got a fluid. It's a miniature type of electrohydraulic shockwave that is delivered from the tip of the machine. And initially when we have taken, we are also not sure whether it works, because somehow the patients who are not responding to PDE5 inhibitors, they need something more than that, and most of patients are not very willing at the first instance for a surgery. Erectile dysfunction, whatever implants are there, they are attractive, there are so many of them available, they are so expensive, but to convince a patient for surgery, it's not easy. That's why this has actually had some role in between. The patients who improve with low intensity shockwave therapy are okay. If they don't improve, they automatically, they'll ask for something more, and probably they will agree for implantation later. You can see the focal length. This is shockwave therapy for kidney stones. The principle is same. So this is a miniaturized one. It's about 1/6 of the shockwave. The wavelength is, focal point is 1/6 shorter than the kidney stone. Now this is easy to do because pineal organ is superficial. You can hold it. You will actually, you see the procedure. We give the shocks at 5 places, both crural and 3 parts in the shaft. Most often, the crural part is very important because from where the blood vessel starts, and any person with atherosclerosis, diabetes, hypertension, obesity, metabolic syndrome, we give shocks actually weekly twice for first 3 weeks. So 6 sittings here, and there is a gap of 3 weeks in between. There is a rest period. After that, another 6 sittings. So on the whole, we are giving 12 sittings, each sitting around 15 to 20 minutes. The shockwave intensity is 0.09 millijoules per millimeter cube. And most of the patients, they tolerate it well. You can see here, we are starting with the crust here. We can actually target the vascular tree, because sometimes we find the calcific spots on ultrasound. There may be some blocks here and there. The PSV may be very less. So we are selecting only vascular erectile dysfunction patient, not neurogenic or otherwise, or psychogenic, or sometimes which are venogenic. So those things don't improve, because what we are trying to target is atherosclerotic plaques, the microcalcification, what is there, only we are targeting. That's why the results will be very good in patients with vascular PD. Coming to these are only results I am showing here. We have done 472 patients, out of which around 80% have done very well. Initially, first 1 month.
Speak this, sir, we'll have to cut down because then the marks will be cut.
This is last slide, sir. Now, I am only trying to say that out of 472, about 80% have improved over next 1 month, and patients who didn't improve, we have actually started on PDE5, which showed improvement. The same patient who didn't have any response with PDE5, after this treatment has very good response. That's why we are trying to advocate or recommend the patients who are vascular erectile dysfunction. The selection criteria should be very good, and the results also only after 9 weeks. That is 20.
Thank you, sir. Sir, we need to time.
Yeah, 12 seconds we are actually coming out with the positive response.
May I have the one against this Dr. Kammela, please? Let us know why you would not want to prefer this. Kammela sir, you can be here with us on stage, please. Can we have it on time, please? The AV guys, please back up. Doctor, you can start without the slide also. I'm sure you've learned them by heart. You can please start.
Hello everyone, good afternoon. Thanks to the USI and Andrology and especially Dr. Raghavendra sir for considering for this debate. I am against USWT for ED. We'll see why, because we are not talking whether it is exciting, whether it is proven. So coming to the guidelines, there is no consensus about the standard of care as compared to other modalities, which are like PDE5 inhibitors or including vacuum erection devices, which have strong evidence. The USWT has only very low level of evidence and the recommendation strength is weak, and it has been only centered to clinical trials in AUA. And even intracavernosal injections, penile prostheses have high evidence, unlike USWT, which is not in first line, not in second line. But not even included in any definitive algorithm so far. So mentioned in guidelines doesn't mean it is recommended. And all this evidence which is growing in favor of ESWT for ED suddenly disappears when it is compared with the placebo. There is no significant difference when compared with sham trials. If a device can't beat sham, it doesn't beat a placebo. And whatever the effect size we are talking about in increasing in the IIEF scores, they also suddenly disappear when it is double blinded. One of the best study in favor of ESWT is Olsen et al., which showed 57% improvement in the IIEF score, which is only 2 to 4 points. But the minimum required MCID in case of moderate to severe ED is at least 4 points. So even this study has only shown that there is improvement, but the improvement is only in mild vasculogenic ED, and even this improvement disappeared after 24 weeks of the study. So there is no real erectile restoration here. The statistical significance doesn't correlate with the clinical success, and our patients want erections, not p-values. So coming to the biology, it says that ESWT regenerates penile vasculature in few studies, including Wadi et al. But it is a very small study, non-pilot, non-sham study, pilot study, mostly representative in the animal and mechanistic data only. So hypothesis generation doesn't convert into practical changes. And coming to the meta-analysis, there is a lot of heterogeneity in the groups and studies which were included in this meta-analysis. The devices used were mixed, the protocols were mixed a lot, and even publication bias risk can be concerned. So pooling weak studies together doesn't make it a strong evidence. And whatever result the ESWT gives, it is very poor in durability. The benefit declines over a period of time. Repeated sessions are required, and if we are calling that as a cure should be lasted. And in real world applicability, it is not generalized to real practice. It is only used in mild vasculogenic ED where PDE inhibitors could also be used. And the poor response in diabetes, post-prostatectomy EDs, neurogenic EDs limits the use of applicability. And out of all, it is not a cost-effective procedure. It is high out-of-pocket cost on the patient. There is no reimbursement. Safe doesn't mean it is effective, and it is our ethical duty to disclose the uncertainty of the results to the patient before convincing